hello again, and I'm going to give a summary. It's not going to last 20 minutes. It's just going to be some things that I think really resonated with me as I heard this and as going down this road. First of all, we in the States at our hospital, we've been doing, not just our hospital, more than just our hospital. A lot of hospitals have been doing the briefing, the whole gamut, and I think that we call things a little differently, but the idea is the same. And initially, it was very difficult to start, because there's a lot of logistic things that each individual hospital had to figure out, their operating rooms, the surgeons, and who's going to lead it and who's going to do it. But now that we've been doing it for about 5 years, I cannot think about doing I would, even if they said not to do it, I don't even know if we're supposed to do it anymore, but everyone does it. And there's no surgeon, even the biggest surgeons and anesthesia, and the people who just hated it the most are the biggest proponents now. Because now they really figured out, all right, this really helps me prepare for the case. It helps the whole team prepare for the case. I know everyone on the team now, where there's much better understanding of what everyone is doing and what, where the gaps are, where the cracks are, that things are falling through and things like that. So this is, I think that it's probably going to be like all change is going to be met by people who are the naysayers and who will just kind of dig in their heels. But it'll come along, and those people may be your biggest kind of advocates once this gets going. I do have just a few things that I wanted to, that I really enjoyed hearing about. And one is just the overall aspect of achieving communication. As I hear about kind of the barriers that people bring up, not just today, yesterday, and in any type of hospital, a lot of it is perspective and context. So the perspective of the surgeon, the anesthesiologist, the nurse, and a lot of times we don't always understand as much of what the other perspective is. And so that's absolutely alleviated by communication. A lot of times that we don't know what we don't know. So we think that the universe is this, and really the universe is this. And so we don't know that unless somebody tells us that. And because it's very hard for some of us, especially surgeons, to learn more because we think we know everything. And so we have to expand it somehow with communication. And communication will get us there. And then that'll lead to the teamwork and whatnot. But the communication is first. That really helps the perspective and context. Now, achieving communication, there are techniques, and I didn't go into this in the talk, but I think that probably the people in the room here, a lot of the staff at hospitals dealing with all of this day in, day out have learned this. And there are ways to deal with it, and a lot of times as we do quality improvement or patient care, there's a science and there's an art to it, right? The science is very cognitive. This bone's connected to this bone, so you gotta put them together with a nail or whatever they do. But there's an art to it. There's a definite art and style to what we do, and the researchers might call it IQ, intelligence quotient, and EQ, emotional quotient. And emotional intelligence now, at least in the States, is getting so much airplay amongst leaders of hospitals, leaders of surgery departments or anesthesia departments, leaders of huge Fortune 500 companies, is emotional intelligence. And it's really having social awareness, relationship management, self-management, emotional awareness of how discussions go, how communication goes. And one of the things that I've found very useful for myself is understanding my kind of level of style in doing things and other people's style. So there is something, and there's a lot of ways that this has been described, but one way is the DISC analysis. Have you heard of the DISC analysis? DISC, basically the premise is that there are 4 personality types, and not like crazy surgeon or sane nurse or things like that, but 4 personality types in our style. And it usually, people talk about it in terms of leadership, but I don't think that's right, because everyone has these styles no matter what they do, and everyone can be deemed a leader no matter where they are, whether they're a leader of a company, a leader in the operating room, a leader kind of for whatever task. And so DISC, D-I-S-C, are the 4 personalities. D is dominant. For better or for worse, dominant tends to be the surgeons. They're swift decision makers. They just kind of like they don't want to hear a long story. They just want to make a decision. It's just kind of a stereotype, but when they do these analyses, surgeons are D's. I, influencers. Influencers are kind of the charismatic speakers that get up and people follow them because of their personality and their effervescence. So that's the I, influencers. S are the people who are steady. They're just kind of like, they don't get rushed. They just kind of go at their pace and make sure that before we get to B, we're doing A. And then after we do A and B, we're going to go to C. And do not try to rush me to C because I am not going there if we're at A. So that's the steady people. And then conscientious people is the C, conscientious. They are the very accurate people. They are people, Bill Gates of Microsoft is a conscientious person. Einstein was a C, was a conscientious person. And they will wait and prioritize accuracy. And so when you're dealing with somebody, and this is what I've learned over and over again, and people have told me over and over again, that when you're dealing with different people, you should know your own style and you should know somebody else's style. Because the way you talk to a D, the way you talk to apparently me, I'm a D, is that you don't give me a long whole story of this. You just kind of say, here's the issue, here's the answer. Whereas if you talk to a S, a steady person, or a conscientious person, then you give them that story because if you just say, here's the answer, they won't believe it. They want to know the whole story. So in the communication pieces, as you're connecting with people, knowing, and this is all the emotional intelligence. This is, as you know, the people you're working with on your team, not just their kind of, are they the idea person or the process person or whatnot, but how they take in the information that you're giving them is very, very important, because you talk to the person the wrong way or lead it the wrong way, they shut down. If somebody gives a D a whole bunch of information, they just forget it. I'm not going to listen anymore. They just walk away. Or if you give an S, just the short thing, here's the problem, we're going to do this, and then you walk away, they're lost, and they won't understand it, and they won't believe it. So knowing that piece in the pieces of communication, and I think that I'm biased, but I think the nurses know it the best. The nurses in the hospitals and the ORs that at least I work in know it the best. They understand how to talk to and how to communicate and how to get things done, just because I think they have to. They had to have learned. So that's a really important piece of achieving communication, of how to communicate, because we know that communication is the important thing. We're going to do it through the briefings and timeouts and the sign-ins and all those types of things, and that's going to foster it. That's going to be the model or the structure by which we're going to do it. But how we do it is almost just as important. And so that's that. I really liked what Liz and Janine said about the year of the nice. Because when we're working many hours, and sometimes it's just terrible days, and you just want to kick the wall, and having as much positivity and niceness and almost fun about it while still doing a great job is really important to maintaining the longevity of what we do day in, day out. If you think about all the professions where there's burnout, it's because that's not there. It's not, the niceness is not there. The worthwhileness of things is not there. So I really enjoyed that when you talked about your year of the nice. I'm gonna share that with other people. And finally, just the last thing is just keeping our eyes on the prize. And is that, when we go, I was talking about from one of the slides of all the programs we go to visit, and the questions we ask them just at the outset is that, how do you know you're good? How do you when you care for a patient, how do you know you're good? And if you're not good, how do you get better? And we get all sorts of answers, but I think that there are three key things that we look for when we develop standards that hospitals have to adhere to, and when we go visit hospitals. So number one, are they performing? However you define performance. Do they have a low mortality rate? Do they have a high compliance rate? When they do the briefings, are they doing it the right way, or are they just kind of like checking off the box and kind of doing something else? performance. Are they performing? Do they have, so that's the first thing. The second thing is commitment. Do they have that commitment? And does everyone have that commitment? Is it just the nurses who have the commitment and the surgeons are in anesthesia and everyone else are just kind of pacing through the steps and not really meaning it? So what is the commitment of the place, of the universe that we're looking at? It's the operating room, it's the single room, it's all of the operating rooms, is it the hospital, is it the whole system? What is the commitment there? And the third thing is that can this place, however you define place, identify and fix its problems? So that goes to the first questions of how do you know you're good? And a lot of places don't look, so they never find anything, and they don't know if they're good or not. And so they can't identify what's wrong, and they can't fix what they don't identify. So that's having a lot of introspection of looking ourselves in the mirror and saying, how good are we? How do we know that we're good? How do we know that we're doing this well? And a lot of these things is, and we're talking about having auditors come in and watch, but we know when we do a good briefing. We know when we do a good, X, Y, or Z. And we should know when we don't. And that's a lot of the professionalism that it takes. That's a lot of the integrity of each of us individually as we do our jobs day to day. Anyway, that's what I really enjoyed, and thank you for sharing all this stuff with me. And I really enjoyed hearing the barriers and the solutions of this last piece. But thank you very much for your attention, and I'm really happy to be here. Thanks.